So I'd like to welcome again Professor Mallard from France, from Toulouse. He started off the short sessions. He's going to finish them off again. And his talk is on traumatic reticuloperitonitis, correlation between necropsy and antemortem clinical and laboratory data.
Thank you, Mrs. Chairwoman. So now a topic not very exotic, but very common in our practices, traumatic reticuloperitonitis, I will say TRP to continue. Okay, the same plan as previously. You all know the problem. Left side, the reticulum, right side, the weapon, a piece of iron or any metal, okay? But the real problem is that TRP is a challenge for the practitioner because all is TRP and nothing is TRP, as you know. Okay? So the questions were interest of the ultrasonography in the diagnosis of TRP, interest in association with other clinical or analytic data, and we promptly restrained it to dosage of fibrinogen, and always the same words by Sebastian Bugzinski and a special promotion on his books. Okay? We wanted to know exactly if the ultrasonography were right or wrong, and the idea was, my first idea was to have a radiography and to see or not to see any iron, a piece of metal in the thoracic part of or between the rumen and thoracic part. But with the charming breed of beef cattle we have in the western part of France, that's to say Limousin, Blonde d'Aquitaine, and so charming beast, it was not possible to have a radiography for all cases. So the second idea was to compare the ultrasonography and the results, the necropsic findings when the cows were euthanized. And we had to measure and to see what we really have seen. The idea, we started in the last trimester of year 2014 with 33 cows with standard clinical examination, ultrasonography, blood sampling, biochemistry, but only fibrinogen, and hematology. We dropped it after 3 cows, so I will not deal with hematology. And to have a complete cases, and we include only in 38 cows necropsy because all cows suspected with TRP were treated with a magnet, with non-steroidal anti-inflammatory drug and penicillin. And some of them could go back to their farm, and the others were euthanized, the 38 remaining. Okay. The breeds, no importance. The age, no importance. We tried to correlate and to give predictive value to breed, to age. No predictive value, as you know. We used here only the MyBli 5 and convex probes, allowing us to see superficially but also deeply, because in some cases in very muscled beef cattle of the we face, we only see the surface of the atrium of the rumen or the reticulum, and we need to have a probe allowing us to go from superficie to deep parts of the cattle. You know where to put the probes, okay, relating to anatomy of the cattle. We have chosen the left side. This is Guillemette Bataille, my student, who performed the thesis. And we analyzed in the same way as the study on the umbilical disorders. We analyzed our results and we tried to measure sensitivity, specificity, PPV and NPV. Okay. The importance with the first figures we faced were important, and we had to choose thresholds or cutoff, and these are the cutoffs we had, and the cases as they are split. Okay. Which is the most important? This is total protein. This is fibrinogen. This is total protein and fibrinogen, and this is our cutoff. The main figures we used are the dosage of fibrinogen, and we will discuss in a few minutes, discuss all these thresholds, okay? No words on hematology because we stopped with 3 to 4 cows. A few examples of the image and the structure at necropsy. Here an alteration of the surface of the serose, and here the result, the same cow at necropsy, of course. Here an abscess and the result at necropsy. Here are adherences and a lot of fibrin and the result at necropsy, and so on, a collection of fluids and inflammatory lesions and the results at necropsy in the same cow. Okay? So, clinical data are decorated with the diagnosis, the accurate diagnosis of TRP. In fact, not. We tried all combos. The unique combos predictive really to TRP is the combo of the 7 clinical signs you have in the first lines. And as you have, you can guess, no cow had all the 7 signs. Okay? So let's go back to the topic of the study, ultrasonography alone. And the ultrasonography was performed before anyone could know the result of biochemistry or other paraclinical data. So sensitivity and specificity, positive predictive value, negative predictive value, they seem very poor, and I will discuss why later, except sensitivity. But all data were due in part because they were euthanized on average 2 to 3 weeks after ultrasonography and diagnosis. That's to say 2 to 3 weeks after treatment. And I suppose that the results at necropsy were changed by this treatment and the delay between the diagnosis and the euthanasia, the time they were euthanized. If you add biochemistry on the sole results of fibrinogen with a cutoff at about 7 grams per liter, you dramatically increase the performances, and which is important, the negative predictive value, which is 1, that's to say the probability to have a real negative TRP when ultrasonography and biochemistry say no, is 100%. Okay? Hematology, I would say, we stopped after 3 cows. So the results, if you want to synthesize them, are here. We do recommend by now, due to these performances, to add biochemistry systematically to ultrasonography. Why could it be better? We have multi-biases of recruitment. That's to say, we don't know when a cow is hospitalized at the vet school of Toulouse, since when the trouble have initiated. We don't know always the treatment the cows had, and we manage them sometimes differently because we have a lot of clinicians in our hospitals, and the protocol, I must confess, is not always the same from clinician to clinician. We come back to the same problem as it was evocated by Professor Koffler, that's to say the standardization. We can discuss the choice of biochemical data. It is the next slide. We can discuss the choice of thresholds. Fibrinogen is even more accurate if the thresholds or the cutoff is dropped from 6 to 7 grams per liter to 5 to 4. But we have chosen, as usual in our hospitals, 6 to 7. And we can discuss also the choice of necropsy as the gold standard. In the next step, we are going to do the same job with cilioscopy, laparoscopy. That's to say, to see all lesions in all cows, including those who feel better after the treatment and who go back to their farm. We don't need to kill them. I think it will be the next gold standard for us to evaluate the performances of ultrasonography. The choice of necropsy is always farmer dependent because a lot of cows had to be euthanized or not, and the euthanizing decision is in the hands of the farmer. And as I already mentioned, there is a delay between admission, clinical and laboratory data, and euthanasia. That's to say, maybe the lesions modify, and I'm sure sometimes they modify because, on average, I told you already, between the entry of the cow and the euthanizing decision, the time lasting is 2 to 3 weeks. Okay. I discussed at one point the threshold of fibrinogen, but you can also choose other acute protein of inflammation, and maybe the results could be different. I didn't try, but it is also a next step to have better sensitivity and specificity than the expected one with fibrinogen. Well, to conclude, ultrasonography in TRP in our hospitals is mandatory because all is TRP, nothing is TRP. After a complete clinical examination, you have a lot of clinical signs, and it is difficult to let them communicate and to give an idea. Of course, as bovine practitioners, when we face a sporadic problem in adult cow, dealing with the abdomen, I would say, we always think in traumatic reticuloperitonitis, okay? But it is necessary, mandatory to confirm it, and ultrasonography seems a good tool associated with a minimal biochemistry. You secure your diagnosis in TRP because the decision in half of the cases is euthanasia, at least in France. Ultrasonography is complementary to gross examination. I say gross examination and complementary. No ultrasonography before gross examination for us as for our students. There is a risk, as you see in the figures, of overdiagnosis, and the overdiagnosis is a trap for the ultrasonographist. I do believe, I speak of myself, is when you want to see something in black and white, you see it sometimes. It's my case, not the case of the panel of ultrasonographists here. Okay? And overall, there is an excellent negative predictive value when biochemistry is used alongside ultrasonography. Thank you for your attention, and thank you for all my colleagues and students.
So are there any questions? Well, thank you very much for a very interesting talk. And I'd like to thank everybody for attending and for all the speakers who gave excellent speeches this morning. They were great.